Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and this is our first episode for 2025. And apologies to all the listeners for a prolonged gap. And I can guarantee you that's not Maddie, that's my fault. So, welcome, Maddie. How you been?
I'm good, but I think you're also a very busy person. So, yeah, you have had a lot of on your plate. And then I think the Christmas and New Year period just goes by so quickly, and before you know it, it's like February, and then now it's March. So, like it's hard to keep up with everything.
And look, it's not on my New Year's resolution list, but I think reflecting on that now, I think probably I need to commit myself to do these episodes more regularly. Especially a lot of people are asking both of us now why there are no more episodes, but also I think that there's some issues with the website. So I have promised Maddie that I will get my act together and work on those things ASAP.
He has. He said that it's on his to-do list, everyone. So
and now it's recorded as well. So yeah, it's my commitment to all of you. Okay, so Maddie, I guess so. Let's dive into today's fellowship snippet. So Maddie, you are taking over care of a long-term patient in your ICU, whom you have not previously met or treated. The patient is previously well 72-year-old female with an admission diagnosis of Guillain-Barré syndrome. She has been an inpatient in your unit for the last 3 months, and she has suffered numerous complications during her stay, but now she's reported to be clinically stable. She has a tracheostomy in situ, and she's awake, responsive, but remains ventilator dependent. So you're taking over as the treating intensivist for the first time. So what would be your approach in terms of assessment and management?
So this is a long stay ICU patient with GBS who's had several complications, but whose main current issue seems to be ventilator dependence requiring a weaning plan. So my approach would involve a multidisciplinary collaboration and review of her history, examination, and necessary investigations to progress her care, aim to prevent any further complications and identify and treat any existing ongoing issues. So from a historical perspective, the initial approach would be discussing with previous consultants who've looked after and getting a handover with nursing staff and allied health, as well as review of the medical notes and recent investigations to obtain an overview of her progress to date and her current status. And the main focus of these points would be one regarding her tracheostomy, so the date of insertion, whether it was surgical versus percutaneous, the size, when it was last changed, her grade of airway in the case of any emergency requiring intubation, and the position of the trachea on X-ray. Then secondly, from a ventilatory wean perspective, what her current ventilatory supports are, if she's had any time off the ventilator or any sprinting, if she's been having any cuff downtime, and her big barriers for weaning from the ventilator and from decannulation of the trachea. So things like her neurological status, her sputum load, her recent blood gas, and any recent chest X-ray findings, and how her cough, swallow, speech, and bulbar function are, because they can be significantly impaired in GBS. I'd also like to know about her complications, so what these are and how they've been treated, and if any are still active, and then to prevent and identify further complications, as she's a long stay patient in ICU, so she's at risk of DVT, so looking at the timing of her last lower limb Dopplers, making sure she's on DVT prophylaxis. She's at high risk of infection, so if there's any devices or lines still in situ, if they're still required and how long they've been in situ for, and if there are any pressure areas. Then from a psychosocial perspective, she's at risk of sleep disturbance, delirium, depression, or mood disorders, so how her mood and sleep wake has been, if she's on any medications to help facilitate adequate sleep wake, and how are we aiding her communication, especially so if there's a communication board or if she's writing or it's with her eyes. Her medication, so any adverse effects, so reviewing the medication chart and ensuring unnecessary medication is seized. From a bowel and bladder perspective, her bowel regime and her feed regime. And then finally, from a muscle wasting perspective, if she's got any contractures, whether there's been physio input, any splints are required. And then the final things would be looking at the GBS itself, how that was confirmed, what treatment was given, and if she's got any autonomic dysfunction with it, and what her current neurology is, whether there's any other comorbidities, and her social supports. So that's all it does actually require quite a comprehensive historical assessment for this long stay patient. The second part would be looking at an exam, so looking at her vital signs and her trajectory, the temperature she's got, if there's any signs of autonomic dysfunction on exam, the ventilator support that she's using currently and her vital capacity, looking at the trachea site itself and its size and what the stroma looks like, full neurological exam to get a baseline neurological status for the start of the week, looking at the skin and any line sites, and then a general exam looking at her if there's any other complications, what her feeding is, whether she still has an NG in situ or whether she has needed a PEG or a RIG, and then looking at the investigation. So the investigation would be tailored depending on her history and exam. Often at this point in her stay, she might not need any sort of routine investigations, but I would be looking at a bedside bloods and imaging, which would be tailored towards depending on the findings of the history and exam. So from a bedside perspective, an ABG if an arterial line is in situ and any recent changes in the ventilation or weaning. Otherwise, she wouldn't need a routine ABG. Bloods aren't necessarily required. It would depend on her trajectory. But at this stage, often I'd be doing bloods weekly or twice weekly or as clinically indicated, depending on her stability, or depending if there's presence of any other organ dysfunction. And then imaging, again, routine chest x-rays aren't required generally at this stage unless there's been complications or any significant changes. But I'll be looking at her most recent x-ray and seeing if there were any need for further imaging.
Thanks, Maddie. So that's a very comprehensive answer, and that's probably summarizes what most of the intensivists do on their first day or second day after receiving the handover. Sometimes it takes longer than a day to just get your head around. It's not an easy task to look after a chronically ventilated patient in intensive care and then start making changes.
And I think it's one of those things that you don't think of as much during training. It's like when you don't necessarily have that more longitudinal vision, which I think comes with more time and experience, or when you're actually responsible for progressing them in ICU.
That's right, because even making small changes in these patients will have a significant implication. So before you start making changes, understanding the context, what happened to them in last many weeks, how are they traveling, how the family is traveling, what are the kind of understanding of the staff who are looking after them, because most of the time these patients are institutionalized and they had certain expectations from intensive. So it's almost trying to understand where they are currently in their journey within the intensive care unit and then trying to meet them there and then almost walking with them in that journey. And I think that's the kind of one of the way to look at it, because if you start making changes without kind of getting them in confidence, then most of the stuff that you're going to do it might not work. So just be mindful that yes, it's not just the clinical medicine. There is a lot of non-clinical stuff that also is important in looking after these patients. So I guess you've done the assessment, and as most of us know, these patients are quite hemodynamically stable. She's also a febrile with no recent infections, no organ failure. The blood looks pristine. Currently, she's ventilated with a spontaneous mode of ventilation with no obvious signs of respiratory distress, with adequate gas exchange. She's currently on FR2 of 30%, and the ventilator settings, she's on CPAP pressure support mode with a PEEP of 8 and pressure support of 12, which is on top of PEEP. She has been on that setting for almost now more than 48 hours, and she has no trial of cuff down so far. So I guess this is a very common question that has been obviously that we all have to think about as an intensivist, but also this is a kind of common theme in exam, that what will be your strategy for weaning during your week?
I think this lady is still on moderate amounts of support from the ventilator without any sprints. But so there are two main branches to my ventilatory weaning plan. The first is optimizing her respiratory function. And then the second part is actually instituting a weaning regime. So from an optimizing respiratory function, this would involve decreasing her respiratory resistance, increasing the compliance, decreasing the respiratory work, optimizing oxygen delivery, optimizing ventilatory drive, and optimizing muscle function. So decreasing respiratory resistance, I'd look at the tracheostomy size, see if there's any signs of reversible airway disease, and ensuring the normal humidification, chest physio, and regular suctioning and secretion management, and increasing her respiratory compliance, so treating any lung disease, infection, or fluid overload, decreasing the respiratory work, ensuring she's adequately positioned, and treating things like fever, pain, or agitation, optimizing her oxygen delivery, so transfusing if she's anemic, diuresing if signs of overload, and treating any myocardial dysfunction, and optimizing a ventilatory drive, so treat delirium, correcting alkalosis. And finally, the big one in her would be trying to optimize her muscle function, so adequate nutrition, avoiding steroids and aiming normal electrolytes, and having ongoing input from allied health. In terms of the weaning regime, be looking at what her respiratory rate is currently, and it sounds like so she's hemodynamically stable and saturating well on the current ventilatory support. So I'd be reducing her pressure support by 2 initially and observing the effects. So often in these cases, the tidal volume will reduce, but if the respiratory rate remains less than 24, she's not obviously distressed, and the SATs and her SATs and hemodynamics are stable, the stable end tidal CO2, then I'd remain on the same. I'd continue reducing this until a point that there is an effect on the respiratory status or hemodynamics, and then increase back up to 2 from that point. So it's a bit tricky because it would depend. It does require like looking at the bedside and reassessing and seeing what the effects of your changes are. I would then be trying a sprint with so say if she's where she becomes very tachypneic with a pressure support of 4, then I'd be increasing back to 6. And if she was stable on that, I'd try a sprint with a PEEP of 8 and a pressure support of 6 for 30 minutes with clear stopping criteria, which we've talked about. So tachycardia, tachypnea over 24, desaturation, or if she's feeling more distressed, and then breaking back onto the previous settings for 2 hours after this. Initially, as she'd had no sprints before, I'd aim for 4 sprints during the day, and that would be between 8 a.m. to 8 p.m. But it would also depend on how she tolerates this. So if she does very well with this, then I'd be aiming to increase the time of the sprint tomorrow. So, for example, 1 hour, 4 times a day, and with an ongoing increase in the sprints, depending on how she tolerates it. Some people can wean quite quickly, but in patients with who are more elderly or with GBS who have been long stayers, often it's a very slow process, and the sprints are actually quite gradual, where it's just a tiny increase in the pressure support for increased periods of time during the day. I would be doing a blood gas in 48 to 72 hours to check her CO2, ensure adequate clearance compared to before the weaning regime had started, as she's had no sprints before. And then once she gets to a stage where she's comfortable on no pressure support, I'll be starting time off the ventilator on just humidified oxygen, with the aim to have a full day off the ventilator with just ventilation overnight, and then 24 hours off the ventilator. And this would involve very close observation again of her respiratory and hemodynamic parameters, as well as the amount of suctioning that she's requiring by the nursing staff.
Yeah, so that's interesting. I always look at the weaning from mechanical ventilation in this chronically ventilated patient as a multidisciplinary exercise, and always make sure that you have clear communication with your staff. And I have to work around the patient daily routine, because you don't want to introduce something new which kind of interrupts their physio, their nursing care, and all those things. So always make sure that you are introducing the weaning plan hand in hand with the chronic care plan, which most of the units have this plan put in place by their senior nursing staff. And again, that's the part of the discussion when you take over on first day, to have a chat with all the stakeholders and start understanding what has been done so far and how can we progress. And as you said, probably the most important thing is to take a baby steps in the weaning. Don't try to make too ambitious changes on day 2, day 3. This is a very interesting question for me, but I want to see what's your thoughts on when you would consider downsizing her tracheostomy.
Yeah, I think this is spoken to a few different people about this, because people have different approaches. But I think that it's first important to understand the purpose of downsizing a tracheostomy. So usually it's allow the patient to be able to have longer periods of breathing around the tracheostomy tube rather than through it, but when they're not yet ready for decannulation. So in order to do this, it'd be to downsize it, some of the preconditions, you'd want them to be able to tolerate cuff deflation, to be hemodynamically stable, and have a patent upper airway, because the whole point of it is to also allow them to breathe around the tracheostomy tube. So I would consider downsizing the tracheostomy in this patient, not at this stage, because she hasn't even had time off the ventilator or been starting sprints or anything like that. But later down the track, if she was unable to tolerate capping of the tracheostomy or finger occlusion, or having difficulty speaking with cuff deflation, either with using the one-way valve or just purely with the cuff deflation due to problems of having air flowing around the tracheostomy. I would also consider it if the main issue regarding ongoing tracheostomy was the need for regular inline suctioning, but otherwise the patient was not requiring ventilation or significant oxygenation. Downsizing often allows for the patient to have like better vocalization, increased comfort, and promotion of some of the laryngeal rehabilitation. However, it can also increase the work of breathing. As you can imagine, it's increasing, you're trying to breathe through a smaller tube with a smaller diameter. In some institutions, downsizing is part of their weaning regime. It's not where I work, but I have read about and seen people use it as part of their normal weaning regime.
So as a candidate, you can answer this that this is not my normal practice as well, because some of the units won't do downsizing. So they will, and this is my practice as well, where I tend to do the cuff deflation. If they're tolerating really well, I tend to usually just take the tracheostomy out rather than downsizing. And that depends on few things. Obviously, the secretion load, how they're handling the secretion, how strong cough is, and all those things. So sometimes the downsizing the tracheostomy is not a routine practice. And if that's not your practice, you can say that. So you don't need to justify why do you do downsizing if you don't do it. But just be mindful that some units will do it.
Yeah, I think it also, it very much depends on the context. Like, it's not a routine part of my practice, but there are some patients, for example, we have one in at the moment who has a sort of an atypical cause for a spinal cord injury, and she isn't requiring ventilation at all, but she's got a very, very, very poor cough. And so it's mainly, and she's already failed decannulation previously. So she's been downsized mainly because she breathes through her airway, but for secretion management, she needs it.
Yeah, that's the thing. And there's other kind of subset of patients which will benefit from that kind of approach. Or sometimes the airway is so difficult that you will rather take a cautious approach and then keep downsizing till you reach to size 6 or something, and then take it out. So again, there are various ways to do it. But as you said rightly, in that patient, you had failed decannulation. So that's a different thing. Now, what is the role of capping of the tracheostomy as a part of the weaning process? So this is another interesting question.
Yeah, this is interesting because it's also very institutional specific, I think. So idea behind capping in some places as part of the assessment process as to whether a patient is ready to be decannulated. Importantly, it can only occur if the tracheostomy cuff is deflated. Otherwise, there's no way for the air to be expired. Capping actually increases the work of breathing because, if you can imagine, it's blocking off the tracheostomy site. The cuff is deflated, and so you have to breathe around the tracheostomy. So it increased the work of breathing and the airway resistance compared to decannulation. So the theory behind it is that it's a good test of the patient's ability to survive decannulation. Prior to this occurring, the other preconditions for decannulation need to be met. Otherwise, there's no point really doing a capping trial at that stage. So the patient no longer needs mechanical ventilation. They have a patent and protected upper airway, and they can adequately clear their secretions. If all these conditions are met, then the tracheostomy cuff is deflated if it's not already been deflated. The patient's assessed, ensuring that they're still able to tolerate with cuff down with no increased work of breathing. The tracheostomy tube is then occluded, and the patient is observed to ensure that they're stable from a respiratory and hemodynamic point of view, and that they're able to cough secretions around their tracheostomy and into their mouth. The duration of this capping trial is different depending on the practitioner, the institution, and the patient. So some institutions just do like a digital occlusion for 5 minutes and then might remove the tracheostomy. Some do it and then cap for a variable length of time. So between like half an hour, I've seen up to 3 days. It's all very variable. There has been a trial in the New England Journal of Medicine in 2020 called ReadyCap, which assessed capping for 24 hours versus decannulation based on patient meeting suctioning criteria. So less than 2 times every 8 hours for a 24-hour period. And time to decannulation was short in the suctioning group, with no significant difference in the number of patients needing recannulation, also who failed decannulation. So overall, I guess you just have to see what happens in your institution and what your preference is regarding capping of a patient. It doesn't have an established role in all places as part of the weaning process for tracheostomies.
One other thing that you need to be very careful with the capping is that cuff, as you said, the cuff has to be deflated. And I think there has to be very clear instructions to the staff about that, because actually the patients who can't voice, can't move their arms, legs, and then that can be quite dangerous scenario. So that's the one thing. The second thing is, as I said, it increases the work of breathing. So there's sometimes there is a chance that it might actually fail the weaning or decannulation. It's a good trial of your successful weaning. It doesn't predict the success 100%. So capping it can be quite interesting. It can be used just as a transient measure to see whether patient can vocalize things, to see the vocal cord strength and how much they can vocalize. And if obviously they can vocalize, then pretty much they're quite safe to decannulate. So can be used as a kind of test rather than the means to achieve the outcome. So thanks, Maddie. So that's the end of our today's snippet. We'll be back with another snippet. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.